to chat about in lower. That's because we'll chat about a little bit in upper as well. It's called pelvic crossing group.
Anybody need it?
So, to understand it, we really have to kind of understand, origins and insertions and how this works. And it has to do with a lot of how we've talked about core activation, core strength, and how that influences some of this ability to stabilize the pelvis.
Something.
So,
Oh no.
I can't really manipulate this person to give them bad posture.
I got that right on the
But flash would pop it on there. All right. Anyway, so what I wanted to do is just to kind of visualize this person with an increased lordotic curve. What does that mean? What is an increased
spine
lordotic
curves out,
curve?
or like that.
That goes in. The spine goes in.
So the spine kind of curves, so there's an increased curve, so the spine goes in, and then the sacrum kind of comes out farther. So we have, long story short, we have a bigger booty. Because that's effectively what it does. It pronounces the size of the posterior. So there's a deeper cave in for the lumbar spine, in through here, where this is then pronounced outward.
Like lordosis?
Now, that can be structural, and on many people it is, but it can also be quite functional. So how does it happen functionally? Well, in this happy person here, what we're seeing is our abdominal muscles up in front. Let me get rid of a couple of them. So you can see how these muscles all attach into the pelvic rim, the pubis on the front. This is this line right here, this white line right up the middle. It's called the linea alba. In the back, if I can get, in the back, you can see how most of the musculature for the back extensors attaches into the pelvis through here. That may be why it's not, maybe why we didn't cover it yet, because it's more of a back thing. So the abdominal muscles insert in through this anterior edge all along the posterior crest into the pubis here. Our back extensors insert into the sacrum, the PSIS, around the SI joint. They really have kind of a pull for the back side of the sacrum to come up. Does that make sense? What inserts on the other end? What inserts distally? That would have a downward pull to balance that out.
Posterior side.
Okay, rectus femoris. We can come in here and see the rectus femoris is going to be off that AIS right there, anterior inferior iliac spine. So that, as well as there's a happy muscle that fills in that gap right there.
Iliacus.
Iliacus fills in the anterior crest.
Wait, what landmark are you using for the other side?
For what?
For the posterior side? Like the iliac crest or posterior iliac crest?
What landmark am I using?
For the posterior, for the other, yeah.
Antagonist.
Back here?
Yeah.
I mean, into the sacrum, all across that. I mean, if I hide these out, you'll see. Well, let's actually get rid of all of them, because there's a few. So they're actually coming into the sacrum and the SI joint, the posterior SI ligament as well. So they're attaching, pretty much anchoring into all of that ligamentous structure and the sacrum itself, as well as, which is going to have a downward pull as well. Because it's attaching in below the sacrum, it's actually going to be pulling on the pelvis as well. So what we've got, kind of like when we talked about the scapula yesterday, we have this balance of muscles that are going to have opposite pulls. Your back extensor muscles are going to be pulling upward. In the front, you're going to have your hip flexors that are going to be tilting it even more And on the opposite side, what's right there? What? What else? Biceps femoris longhand, what is semimembranous, semitendinosus. So we have the common origination point for your hamstring muscles. What's the bony landmark there?
Ischial tuberosity.
Ischial tuberosity. So cross pelvic syndrome is really something you'll find in people who have.
Lordosis. Lordosis.
They're noticeable because they have an increased lordotic curve. So this cross idea is that this through here gets all kind of out of whack. So the muscles of the back extensors through there are fighting the muscles that are pulling down in the front for hip flexors. And then my hamstrings through here are further fighting my back muscles up through here. So if I'm actually increasing this lordotic curve, that means that there's a lot of inactivity going on, to where if the hamstring muscles are tight, it's going to cause a lot of stress in the low back. If the core musculature isn't firing, it's going to increase the possibility of having this lordotic curve accentuated. So we're going to see all kinds of issues with these individuals. And I think, as I'm talking about now, the reason it wasn't brought up yet was because we were going to approach it more in the head, neck, and spine. That's fine, we'll see it again. But we'll certainly talk about it as well when you look at it, because there's an upper cross syndrome as well, to where you get people who, the whole concept of bad posture, to where you sit upright, the rhomboids help retract your shoulder blades. As people have bad posture and sit at a desk and they get the rolled shoulders and the slump forward, and over the course of a very long period of time, by the time you're 35, then you're crunched over a desk like this. So, it's a very dynamic kind of balance between, that has to do with this rotation of the pelvis as it tilts forward and backwards, as it's balanced between the muscles that pull, between the hamstrings that pull down here, the core musculature that stabilizes the front, the back extensors here that tend to get not used enough and slack, and then tight hip flexors as well. So you can kind of see how that kind of creates this cross-pelvic syndrome, in which you're going to have an increased lordotic curve, and it's coming from your tight hamstrings, inactivated core, and can lead to low back pain. So much of that has to do with how we address core activation to create more of a flat back and stabilized back, which unloads those muscles, and then making sure the hamstrings and the hip flexors are adequately in a functional range of motion. So what do you consider a functional range of motion for your hamstrings? How flexible should you be to be a human being? Should I be able to do ballerina and put my knee to my forehead every single day? Not necessarily.
Say 45.
45 degrees of flexion.
Extension.
Extension. We'll do 1 degree, 2 degrees, 45.
Let's say 45.
What is it?
I'm going to say absolute minimum of 70, not 170. 90 usually makes me happy. If they're at least at 90, I don't touch them. I don't need to stretch them to push them farther
Extension.
than that.
Did you say extension or flexion? Extension, right?
Hamstring flexibility.
Okay. Extension.
Hip flexion. So, side note, we'll revisit this again later as we go into back. Cool? Cool. So what do we have? We have a presentation. And then we're going to do some video analysis. The exam. I would go through PowerPoints. I'd either print the PowerPoints off, cut them up into little cards so you can create note cards quick and easy, or I'd go through and make note cards per injury. So print them off as like individual slides, and then boom, you've got note card sets. Or take the time and actually write them out, which can help reinforce the information as well. Have an injury on one side and permanent information on the other.